going to go ahead and get started here, and there's our friend Sherlock for our mystery cases. And so sometimes our cases aren't so mysterious, but we'll see how mysterious this one is. And so we'll go ahead and get started. And so we have a 39-year-old gentleman who's been in the Army for 18 years. And so he presented to our clinic in August for evaluation of cardiovascular disease. He has a family history. We see a lot of the military, with basically a lot of military people have a lot of confidence in the work we do and are interested in exactly what we're testing for and how quickly we get to the bottom line. And so it's very military in its orientation. He has an uncle who had bypass grafting twice and another uncle who died of a heart attack. He denies any symptoms himself, but he's here to find out. And so he has a history of some hypertension, hyperlipidemia, which is somewhat uncommon on our military people because they exercise a lot and they seem to eat pretty good diets now. Things have changed a lot. And he's being medicated, as you can see. The post-traumatic stress disease is something new that we see among people, and got to be very careful about that. As a matter of fact, we had someone with a defibrillator that really aggravated his PTSD.
Oh.
You know, an automatic defibrillator that could fire off at random any time, and so that could be a big concern. So we got to always keep this in mind when we're taking care of military who've been in the theater at the front. So basically, he had unremarkable physical examination, as most of our military guys do. And what to do next is always problematic, and we don't have Pooh today to guide us. So, of course, we always go to an EKG. So let's look at an EKG. And we've got this EKG that doesn't quite look normal, kind of a tall R wave in lead 1. And basically, there's an early transition of R wave. ST and T waves don't look very mature. And so it's a little different. Bradycardia is pretty common in our military guys because they work out, and so they have a high parasympathetic activity. And so echocardiogram was normal. I can't show that today, but we'll retrieve it next time. But we do have a CTA because we go directly to CT. That seems to be the most cost-effective. Show me the anatomy. So we will show you some anatomy. So show me the anatomy. We always put anatomy first in our lineup because it's so much more effective to start with the anatomy and then go from there, especially if you have low radiation procedures. And so basically looking around here at his coronaries, you see a nice big right coronary that's going underneath there, and it's like sitting on this cloud, so let's get rid of the cloud. So we'll just trim a little bit off of the bottom. The nice thing about this is if you're a cardiologist who's a frustrated cardiac surgeon, you can get in on the action. And
I love it.
Actually, do no harm, do no harm. So there we go. I hope that didn't hurt much.
Nice.
Wherever he is. And so there we go. Now we can see the right coronary
Beautiful.
in the AV groove and under the interventricular, inferior interventricular sulcus. And and then we come over here and we see the circ, and it's got its territory. And sometimes you see little things like that, and I don't know what that means until we get inside the vessel. And so, but we do see something interesting about the left anterior descending. And
it's a lot smaller than it ought to be.
Well, it's interesting that it comes down like this, and all of a sudden it gets very small, and then it gets big again. And
Which
so
is a tip-off.
It's got this interesting area, and actually what happened is it's epicardial here, and then it takes a dive into the myocardium.
Oh!
And then it comes back up again, and it's epicardial again. And so
that is so slick.
It takes this dive, you know? And so this is called a myocardial bridge. Why you call it a bridge, I have no idea. It's very common in goats and common
It's actually a tunnel.
And so, yeah, it's common among many, many animals. And in people, it's in the LAD and diagonal. It's about 15% incidence in people and usually means nothing. But there it is, called a myocardial bridge. And what is the significance of that? Well, let's go inside and look at it a little bit and see what this looks like. We can come over here and look at it and see how it makes that dive. And so here we are where we're going to make the dive. And here it goes. It goes along here, and then it dove. It's in. It's in the muscle. It's buried in the muscle now, intramyocardial, and then it's back out again, in and out. And so let's go back over here, and let's take a look at this with our vessel view. And so show me the vessel. We've got our vessel probe, and we're going to probe it. One little click, and it didn't like it, so we're going to have to extend it ourselves because it said, what happened to the LAD? And so the program didn't even like it and couldn't find it. And now we go up this way. Whoops, it still is. Look how it doesn't like that.
That's interesting.
It says, what do I do with that? I don't know what to do with that. And so we can't actually get it to even show the vessel as it dove in there. Let's go inside the vessel. That would be fun. So let's go inside the vessel. Let's go back here to the gallery. Let's go to where we can do coronoscopy and see what we can do with that. So let's go find the vessel here again. And here we are up on the vessel. And here we go taking a dive. And so we're going backwards. So let's go. That goes back. Okay, that goes forward. And we're coming on through there. Here we go. Hold on to your hat. We're taking a dive. And we're actually intramyocardial in this vessel, wandering around in here now. Whoops. We fell out. Let's go back into it again. Oop. And here we go, wandering around in here. This is like a fantastic voyage.
This is really awesome.
Yeah, so here we go. We're going down this guy, taking a trip where no man has gone before.
I take it that's a little bit of vessel that we just passed by with a few specks of calcium in it?
Yeah, some of it is actually contrast. It's probably not calcium at all. It probably we've got a contrast clearing mode, and it probably didn't get rid of the contrast. So now we're intramyocardial. Welcome. We are intramyocardial, and look how small it is down there. Whoops. And so we fell out again. But
can we do a systole diastole gating?
Yeah, well, unfortunately, we only do systole. We only do diastole. We only do diastole. So this is actually constricted and narrowed during diastole.
Okay.
It's not just a systolic event that we're seeing, because we do the lowest radiation possible, a LARA, so we don't have the liberty of having diastole and systole, only diastole. We used to do that when we were doing higher radiation procedures, but we found that prohibitive. And so there we are. You can see we're intramyocardial here, and that's the way it is. So that's interesting. So why does that exist? Why does that happen? Well, it seems to happen a lot among the other animal kingdoms. So hang on for a minute, and we'll get back to our PowerPoint. So basically, I said that was interesting. I said it's got this narrowing, but I said, what have we done that might not be right? Perhaps I induced that somehow. And so what do? Well, we give patients beta blockers to slow down their heart rate. And so he has a pretty slow heart rate. You saw in his EKG, but we may have given some beta blocker. And then what else we do? We give them nitro to dilate their arteries. And so maybe we should do this without that kind of stuff and see if it's what it looks like naturally. Maybe I induced that.
See if he's got weird physiological responses.
Yeah, and maybe I caused vasoconstriction or something. Maybe that's spasm.
Vasodilator.
Maybe it's spasm that I caused. So let's go back and
let's look
at it. We brought it back and did it again. So hang on. Now this one is a little different, and we do have systole and diastole, because we decided we would go back and get systole and diastole and see if there's any difference.
Okay.
So we do have systole and diastole. Unfortunately, they're not the greatest images that occur with the systolic stuff, but you know, we can actually see some of that stuff, and we got diastole, which is much better pictures. It just stays buried, and it stays kind of the same, depending upon, this is a later image that we made, same technique, same everything, except we didn't give drugs this time. We're out without drugs, and so we'll look at that and see if we can get in there and look at it. So hang on here.
It looks pretty okay. It's still small.
And it's still buried inside the myocardium. It looks a little bigger than it did before. It looks bigger than it did before.
Yeah.
It's not exactly as tiny, but it's buried inside the myocardium. It is buried in there. Okay, it is intramyocardial, not epicardial. And so if I profile it here, you can see here it's going along, doop-de-doop-de-doop, and then it comes down here, takes a dip, and then comes back up to the surface again. So very interesting. Happens in a lot of animals. A lot of animals do that. 15% of people, but cows, goats, lots of them have that very commonly, all the time. Normal for cows and goats and stuff. So let's go out of there again, and let's talk about this so-called myocardial bridge. Now, during systole, that's going to be smaller, although I have trouble demonstrating that because the images during systole, well, here we go. Here's an image during systole, sort of, and you can see, you know, it disappears. During systole, it is gone. And so basically it squeezes down in systole, and it's not present. Okay, it just totally blocks the artery off during systole. So there's proof of that. So we've got that information. Okay, and we can do 20. We can go in different phases of systole, and but it's gone. It's gone there. It's no longer exists. So let's go back to where we were before, and we'll talk more about this.
Okay, I've got an idea.
Yes.
I would like to go ahead and dial up his heart rate by external pacing while really looking very, very hard at the left ventricular leads to see if we can induce some degree of ischemia on a rate basis.
That's a great idea because I'm concerned about this guy. He does have some chest pain. Are we missing anything? What can we do to simulate exercise? And so we did. We did exactly what you said. We gave him a milligram of atropine, and we put him on dobutamine drip at 50 mics per kilogram per minute. That's max. And so we got him going really fast. We did a PET scan at the same time. We give rubidium, and we make these beautiful pictures, and we look at the systolic events. We look for ischemia. We look at myocardial perfusion, all these things at one time during a heart rate of 173, you know. So basically, despite having a long arrow narrowing in the intramyocardial segment, 25.9 millimeters of the LAD, the patient does not have ischemia demonstrated by atropine, dobutamine, PET CT. Okay?
Beautiful.
Maximum. And so he did have chest pain. But, you know, we are stimulating his heart rate, making it beat very fast. And I'm not surprised that he had chest pain. So let's go on to case number 2 that's going to talk more about this mysterious finding on patients. So here's a 73-year-old Caucasian male with a history of coronary artery disease, presented to our clinic in March 2013. He's going to have some brachytherapy for prostate cancer. And so he was getting this evaluation of somehow, and he had some SPECT scan years ago, and a SPECT scan, the first SPECT scan he had, just like SPECT scans are, was negative, and the second one was positive. There's never any continuity, but it did maintain its 50% false positive, 50% false negative, flipping a coin rate as being consistent. And so they told him, you don't have any coronary artery disease, you're fine. And then he went to St. Joseph's Hospital in Atlanta and had a scan, and they said, no, you've got severe multivessel coronary artery disease, and he wound up with bypass surgery. So the old SPECT scan didn't let us down. It's remained consistent with 50% false positive, 50% false negative, and you completely ignore the results. And so moving on, basically prostate cancer, hormone therapy, brachytherapy, coronary bypass surgery, non-smoker, blah, blah, and normal physical examination, and everybody gets an EKG, even though Medicare actually looks to see if there was a reason to do an EKG. I can't believe that. You come to a cardiologist's office, how can somebody want to know why you did an EKG in a cardiologist's office? But anyway, here we go. We've got normal sinus rhythm, sinus bradycardia, nice heart rate for a CT. Whenever I see a nice bradycardia, I'm very happy. And we got kind of a discoordinate, not concordinate, but discoordinate T-wave vector. The T-wave is taller up here in V1 than it is down here. PR interval looks a little on the long side, a little dippy, shallow ST segment there, and that's about it. And so that's interesting. And we did an echo, it's normal, and everybody has a little diastolic dysfunction in his age, and he's got a little plaque in both carotids, not really correlated well with how much you got in your heart. And what are we going to do next? And so we decided, let's look at the anatomy. It's always about the anatomy. It's about the anatomy, stupid. That's what I say. Okay, so here we are. We have someone who's had bypass surgery. You see all these pipes going around.
Yeah.
Here's one going over to the right coronary. Here's one going over to a diagonal. Here's a lima coming into the LAD. It looks like we got lots of pipes coming around there. And we look at the vessels, and we see our friend the LAD coming down. Looks like it's got a lot of calcium in it, which makes it a little wider externally and a little bigger because you get positive remodeling. And so looking at our friend the LAD, we come where it stops here and moves on there, and it looks a little different there. So let's go check out the LAD and see what's going on with that boy. So hang on here, and we'll give the LAD a check. So this is very interesting.
And this is not a bridge.
This is very interesting. No, it is a bridge.
It is a bridge.
Took a dive into the myocardium, but look what happened. It's very amazing what happened. Is we're going along, severe coronary artery disease, atheromas, end-stage calcification, all of this stuff, and all of a sudden we take a dive intramyocardial, and there's an abrupt. It quits. There's no more atherosclerosis.
It's protective. We ought to go in and bury everybody's vessels.
Yeah, look at that. We should be sheep and goats, right?
Yeah.
So look at that. It just stopped right there. Isn't that?
That's astounding.
It's amazing. There it is. We're in there, and it stopped. And so let's see now. What is going on inside here? What? Now, this is really interesting because I don't know if anybody's ever talked about this. Maybe let's make a little change here. I'm going to change my Hounsfield units, and I'm going to dial down to 30. And so I'm making red 30 now. And so this is muscle. This is muscle. This is what muscle is. I'm going through muscle, and you're seeing Hounsfield units. Now I'm going through contrast, and you're seeing Hounsfield units. Now I'm going through fibrosis, okay, seeing Hounsfield units. Now I'm going into something called fat. Fat. Let's see. Red is programmed for fat. Let's take this and move it a little bit, and we're changing our program a little bit, and we're changing this to just a very narrow zone, and so it almost, I don't think it's there. I don't think that's the same thing. Yeah, I think we were able to obliterate that, because I was wondering if there was epicardial fat in the myocardial, but there's not, because I was able to cancel it out. and I made a very narrow zone and canceled that out. I don't think that is fat. So basically what I have is the vessel took a dive intramyocardial, it lost its epicardial fat, and then it comes back out again, and it lost its atherosclerosis. So let's talk about what that means, okay?
Muscle is good for vessels.
So here we go. We got, incidentally, information. Patent Lima to the LAD, patent Rima to the PDA. Why would anybody who had bypass surgery that has, you know, so many different changes that take place technically when you do it, why wouldn't you want to know if your grafts are open? People go 10 or 15 years and they never know if their grafts are open or not. And there's a 60% closure rate of vein grafts at 10 years. And the people we see at 15 years usually have all their vein grafts down. And if they get one problem, such a GI bleed or whatever, that trips them over into severe cardiac ischemia, and they're sliding down the drain. So it's really important to know what your grafts look like. And so I would think everyone should get them looked at. So small circumflex, I want to know too as the doctor, because I want to prevent that 2 o'clock in the morning call. And so I want to know what's going on. So the LAD is totally calcified, but until it gets to the area where it ends abruptly, the atherosclerotic process ends abruptly where the artery becomes intramyocardial and takes that dip. So that's kind of interesting. Let's think about what's going on. So myocardial bridging of coronaries, it's segmental intramyocardial course of major coronary arteries, use the LAD and diagonal. During systole, the vessel was compressed. We saw that on the first case. First recognized 200 years ago, somebody doing an autopsy and dug it out of the myocardium. First recognized angiographically, Mason Sones and others. And so some studies have reported that it's a protective effect on the development of atherosclerosis at the site of the myocardial bridge because there is what? Well, no fat in contact with the artery, and we showed that. We changed the Hounsfield units and showed that's true. The vessel is straight. Well, it did look pretty straight, and you know, it takes those bends and curves to get eddies and vortices that are responsible for different stress and strain that may be resulting in deposits of atheroma. Because compressed during systole, I have no idea. Has no branching. Well, we know coronary disease occurs more at the branching areas. And so, and there are changes that occur proximal and distal. Atherosclerosis predisposition proximal and some intimal thickening distal. So I'm not sure which one of these is important, but let's say no fat. It could be no fat in contact with the artery. Let's assume that might be so. So look at this. You may have heard of something called brown fat. There's something called visceral brown fat. Well, it looks brown. Where is it found? Well, it's found, these are under the clavicles, it's pretty big. Anterior abdominal wall, inguinal fossa, between anterior neck muscles. Those are big places to find it. It's found in kids. It's found in young adults. As you get older, you get less of it. But it's very important for non-shivering thermogenesis and can be responsible for a significant amount of body heat if you're exposed to cold. We'll show you some stuff about that. But the epicardial coronary arteries have this very metabolically active brown fat enclosing them. It's like a thermal jacket. And so these things are really high in mitochondria, the powers of the chart of the cell, the mitochondria, because that's what generates the heat. And very, very interesting. And here's some brown fat. And you can see paravertebral, you can see the supraclavicular, subclavicular, you can see around the scaphoid. That's kind of interesting that they're actually around the scaphoid there. And so you see up the neck, you can see around the carotid artery there's brown fat. Pretty amazing stuff. And this brown fat is an FDG study to show it's highly metabolically active. Here's the heart compared with that, you know, and this looks like some blood pool in the heart. and it's highly metabolically active. So brown fat is all over the place in here, especially in a young person. This looks like a young person who was being screened probably for cancer or something, and you can see all the brown fat. Epicardial, pericardial, paracardial, fat. Here's the fat that's everywhere. Here's the fat that's around the coronary arteries. This would be the right coronary artery in the AV groove. This would be the circumflex. There's all kinds of fat around the heart, the periaortic fat. These are all jackets. They've got little jackets on in case it gets cold. You're going to be able to keep warm, and you keep your vessels warm, then you keep your blood warm. You keep your blood warm, that's going to help tissue stay warm. So it's a very positive thing to have this brown fat, especially if it's cold out. And so here's some more subcutaneous. Here's subcutaneous fat. That's not brown fat. That's called white fat. Here's pericardiac fat, para. This is epi. There's peri. And so we've got all this fat around, some of which is brown fat. In brief, the brown fat provides an internal heating jacket that overlies parts of the systemic vascular and on signal. What are those signals? Well, epinephrine. You get cold, fight or flight, you're going to try to warm up. So epinephrine is a positive signal. You're also going to find out that BNP is a positive signal. That's weird. On signal becomes an active metabolic heater applied directly to the flowing bloodstream as it passes to and from the cooler periphery. Amazing. That is amazing. And here we go. Here is brown fat in different age groups. This being young, older, older, much older. And so this guy looks like he's probably about 7 years old or so. He's got an FDG study, probably looking for cancer. And this is his brown fat. And then they submit it to make him, challenge him by cooling him. You can just stick your hand in cold water, and the brown fat looks about the same from here to here. But you go down to this one, who's like 17 or 18, and you can see it heated up. And the cold water made a big change on this one. And so you just put your hand in cold water, and all of a sudden this stuff starts getting hyper-metabolic and going crazy on these thermoclines that are here. And then you come down here, and you can see a big difference in this one in terms of heating up over here with cold water exposure. And then this one, it looks like it heats up quite a bit up in the neck, especially on the left side here. So it responds to certain stimuli, epinephrine, cold, putting your hand in cold water, putting your face, anything cold. So the detection of metabolically active brown fat, which is brown adipose tissue, fat, has been shown to, it decreases with age. Yeah, we see that. There it is. This is somebody in their 80s, and so it did decrease with age. All the fat does, even subcutaneous fat. Let's see, inverse correlation with BMI and fat content. So if you're a bigger person, you have less brown fat. Okay, maybe this person's heavier, less brown fat. And then increase with exposure to low temperature. Well, we certainly demonstrated that if you have chronic exposure to low temperature, not only does the metabolic activity increase, but the brown fat increases, and some of the white fat becomes beige fat, which is hypermetabolic, got a lot more mitochondria, and is similar to brown fat, except it's not quite as brown. And so, and it's lower in diabetic than non-diabetic patients. It's higher in women than in men. Well, they seem to have more subcutaneous fat anyway, thank goodness. And it's lower in diabetic than non-diabetic patients. And so just the people who need to be hypermetabolic and to burn more fat, diabetics, people who are heavy, who have more fat, are not burning it. The detection of 18 FDG brown adipose tissue in humans is modulated by beta blockers. Well, sure. I mean, it's increased by sympathetic, and so if you block the sympathetic, then it's going to decrease. and a single dose of 80 milligrams of propranolol taken orally basically leads to zero brown fat. Like this. It would be almost like this, except that wouldn't be existed either. So, man, so we didn't really realize this. Patients were putting on beta blockers were turning off their brown fat.
Mm-hmm.
Patients with migraine get beta blockers, coronary artery disease gets beta blockers, everybody gets beta blockers, and we're turning off their brown fat. Maybe they're gaining weight. I'm not sure. It's a significant thermoregulation, significant catabolism. So let's look some more. Oh, isn't this interesting? Janet Mora would be interested in this, that Entresto increases BNP, well, we know that, which increases white fat conversion to beige fat and beige fat conversion to brown fat, which increases metabolic activity, and people with obesity have less BNP because of their basically reacting with naproxen. Basically, there's a substance that decreases the BNP and metabolizes it. Entresto has something in it called subutril, and subutril basically blocks that metabolism of BNP, and there's more BNP around, so then therefore there's more stimulation to make beige fat and to make brown fat. And so that's interesting. It'd be interesting to see if our patients on Entresto lose weight. Well, they do, but they may be losing water weight. So you got to see, are they losing fat weight? And that can be measured pretty well. And the last one we put on Entresto, came back to what we call perfect body weight in terms of water weight. And then she lost weight because, one, she felt more mobile. She could do more stuff because she was more active and had less fatigue. But she did lose 10 pounds since September, since being started on Entresto. That was not water weight. That was fat weight. Of course, we can measure that pretty easily. With an MRI, can measure fat. We can get a real good approximation of how much fat there is. We can also measure pericardial fat, epicardial fat with CT. So let's see a little bit more about this. What's the relationship of epicardial fat and coronary artery disease? Well, we saw that people who have myocardial bridges don't have coronary artery disease at those sites. How about maybe the brown adipocytes are doing something? Maybe they are migrating into the plaques, and here's proof that that happens. Maybe they're secreting stuff, that's causing things to happen, with the artery. Maybe some of the fat's migrating, maybe stuff's being secreted, maybe there's a lot of activity that's going on with that brown fat. Maybe that's why Inderal is helping them, because we're turning it off with beta blockers. And so this gives a whole hypothesis of what might be going on in the metabolism of these patients that have this epicardial brown fat, because everybody has it. So epicardial fat, with its close proximity to coronary arteries, has been suggested to be a significant predictor of cardiovascular disease. It didn't say causing, but it says predictor. The close relation between epicardial fat and low-grade inflammation is likely to contribute to the development of cardiovascular disease and obesity. That's an interesting statement. Given the growing evidence that pericardial fat may be an important therapeutic target in the prevention of coronary artery disease, further research in this area is warranted. Conclusions. Epicardial adipose tissue volume assessed by CT was an independent predictor of ischemia on PET and outperformed coronary artery calcium score. Not surprising, because the calcium score is really non-metabolically active coronary artery disease because it's end stage and it's been calcified. It's not liquid plaque. That's dangerous for metabolically active. Outperformed calcium score in a CAD naive population at intermediate pretest probability of disease. Very interesting. Epicardial fat volume was significantly correlated with the extent and severity of coronary artery disease. Where are we getting some stuff here? Patients with non-calcified or mixed plaque had a greater epicardial fat volume than those with calcified plaque. And so, several lines of evidence support a role for epicardial fat in the pathogenesis of coronary artery disease. close anatomical relationship, positive correlation with presence, ability of adipose tissue to secrete hormones, cytokines. So, well, let's see. There it is. Yes, look. This is just gaudy adipose tissue, visceral adipocytes, perhaps brown fat. Look how active it is. Inflammation, atherosclerosis, adiponectin, thrombosis, insulin resistance, type 2 diabetes, atherogenic dyslipidemia, hypertension. Wow, that stuff is very, very active. Tissue necrosis factor alpha, CRP increasing. Lots of stuff going on here. Well, the same kind of stuff is going on with epicardial brown fat. Okay, we've got high protein content, high rates of fatty acid incorporation. That's free fatty acid there. We've got low rates of glucose utilization, and that's occurring over here in the insulin resistance with the increased lactate. We've got low expression of messenger RNA lipoprotein lipase, and don't see that one here, but oh, there we go, lipoprotein lipase. So this same thing is going on in brown fat that's going on in white fat and subcutaneous fat and abdominal fat, and this is very, very important. Focal, epicardial, and pericardial FDG activity is brown fat. So brown fat has a really interesting correlation with coronary artery disease. Perhaps these coronary arteries that take a dip into the myocardium are protected because they lose their brown fat, which we showed that with our coronary CTA. Perhaps this is a whole field that needs to be explored. Perhaps there's some weight loss opportunity here, especially if we basically have the opportunity of capturing all this brown fat and, one, increasing the white fat to be beige fat, causing hypermetabolism, which results in weight loss, causing this activity to increase, but well, people are uncomfortable when they're cold, so we don't want to. You can just put a cold glove on maybe with some ice water circulating through it and turn all this on. You can take if you have hypertension, perhaps this is the best drug for you because it's got angiotensin receptor blocker, and it's got a BNP increaser by blocking neprisin, which is the metabolizer of BNP, and causes more BNP to convert white fat to beige fat. So lots of interesting implications here that need to be explored. We have patients that have hypertension that are obese, and I'm actually putting on Entresto. There are some experiences in Europe using Entresto for hypertension. This might be a very attractive thing. You'll control your blood pressure and lose some weight if everything's done favorably, if you stay off the beta blockers. So we'd like to ask for some questions and see if anybody can bring some stuff up here. Bob, what do you think about all this?
Well, it seems to me that cytokines are absolutely central, and it seems to me that Entresto, you could really do some very neat studies having people on their baseline antihypertensive medicine and seeing what all changes when you change the pharmacologic management. Now,
do you know anybody who's hypertensive and obese?
How about me?
Oh. So we do have people around that are hypertensive and obese.
Sure.
So perhaps this is a new opportunity because you can use this drug off-label.
Oh, yeah.
And how many people have tried to get rid of extra fat and failed with every chemical formula known to man and every opportunity?
Okay. How much is Entresto? Is it an expensive drug?
Entresto is an expensive drug, but the drug companies have been able to manage to negotiate good rates with, like $10 out of pocket, for a patient. So even though it's a $4,500 a year drug, the insurance companies are paying for it for stage 3 and stage 4 congestive heart failure, and it's remarkable. Remarkable.
Very effective therapeutic agent.
Yeah, so let's take a look at this on your next visit to Tampa, because it certainly gives us new possibilities for developing weight loss treatments and perhaps the induction of brown fat. We have PET scanners with FDG, so we could basically measure this quite easily and measure how much brown fat we've turned on and how much beige fat we've converted from white fat. So we can do that with our PET scans very easily, and we have MRIs that have superb measurement of the fat content of the body, and that's better than plunging people into a barrel of water and trying to figure out how much fat they have. So we've got all the equipment to be able to engineer that at discount prices. So we could come up with a very nice formula for looking at that. So isn't that interesting that intramyocardial bridges has led to this discussion?
Yes. This is wonderful. The images are just spectacular.
Thank you. Janet, do you have any comments you'd like?
No, just I agree. I think it's very interesting, and as a cardiac surgery nurse, I know that the surgeon spoke a lot about, how difficult it was to care for some of these patients who had a tremendous amount of adipose tissue around the heart, and how it seemed to complicate their disease. And interesting how the difference in the diabetics versus the non-diabetics are related to this brown fat. And certainly it's an interesting point to consider about a drug maybe like Entresto that might help convert some of that white adipose to brown adipose tissue. So I think it's a very interesting topic.
Thank you so much. Well, my comment is it is very interesting.
I love it.
So thank you so much for attending today. This is recorded, and so this will be available at cardiaccarecritique.com at our website. We're going to continue Wednesday mornings at 7. We'll let you know if there's any change in the future. And thank you for your contribution, and thank you for your encouragement.
Can I ask you to hang on for long enough to show me a patient I have an interest in who you have on your computer? It doesn't have to go to everybody. But,
okay, so we'll shut down the meeting for everyone except you and me, and we have someone that we want to review.
Yeah, perfect.
Okay, thank you so much, everyone.
Thank you, Eric.
Next week.